Thank you for joining our Debbie's Dream Foundation webinar series. Today's webinar is featuring Dr. Omar Llaguna, who will give us a presentation on HIPEC. I'm Brittany Starks, Communications Coordinator for Debbie's Dream Foundation, and I will be moderating today's webinar. We would like to thank our webinar sponsors, title sponsor Merck, platinum sponsors Astellas, Daiichi Sankyo, and Zymeworks, and gold sponsor Bristol Myers Squibb. First, I will share information about stomach cancer and Debbie's Dream Foundation. Then we will hear a presentation on HIPEC. The presentation will be followed by a Q&A discussion. You can type your questions throughout the presentation into the chat section that appears in the webinar menu. We will address questions at the conclusion of the presentation as time allows. This year, nearly 30,000 Americans will be diagnosed with stomach cancer. Stomach cancer is the second leading cause of cancer deaths worldwide after lung cancer, with a dismal 5-year survival rate between 20% and 30%, depending on the country. Many patients are asymptomatic during the early stages of stomach cancer, leading to late diagnosis. Debbie's Dream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally for patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiesdream.org. Pictured here is Debbie Zellman, the founder of Debbie's Dream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April 2008. She had no risk factors and only vague symptoms. At the time, she was told that her chance of being alive in 5 years was only 4%. Debbie founded DDF in April of 2009 and dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Simultaneously, she endured harsh chemo regimens and targeted treatments and experienced many reoccurrences. Unfortunately, Debbie passed away on December 23, 2017, at the age of 50 after only 9.5-year battle with cancer. As an organization, DDF continues her important work and legacy. In a few short years, DDF has achieved many great milestones. We have 32 chapters across the US, including in Canada and Germany. Our PrEP program helps patients, their families, and caregivers match with survivors and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We also have provided $1 million in research grants to date. Each year, patient advocates come together at our annual Stomach Cancer Capitol Hill Advocacy Day with the ultimate goal of securing funding from the Department of Defense's peer-reviewed cancer research program, which allocates funds for stomach cancer research. Here, you can see some of our upcoming events. To learn more, visit our website at debbiesdream.org. DDF is headquartered in Plantation, Florida. Our office hours are Monday through Friday, 8:30 a.m. to 5 p.m. Eastern. Also on this slide are important phone numbers and email addresses you can use to contact our office and staff. We will now begin the presentation on HIPEC with Dr. Omar Llaguna. Dr. Laguna is a surgical oncologist at Memorial Healthcare System. He treats patients with a variety of conditions, including gastrointestinal cancers, melanoma, soft tissue sarcomas, and peritoneal malignancies. He also provides HIPEC and performs robotic surgery. We would like to thank Dr. Laguna for taking time out of his schedule today. And now I will turn the presentation over to you, Dr. Laguna.
Hi, thank you for having me. I'm always happy to talk about some of the newer advances in the treatment of different GI tumors, specifically gastric cancer. I named this talk, HIPEC for advanced gastric cancer, there's something in the water, because this is still a treatment that's much in its evolution. And while there's still a lot more to be done with regards to research to fully document the benefit of the treatment, there seems to be an overwhelming trend in the data that's available to suggest that this treatment, when applied to the right person, does offer a survival advantage. And next slide. So we're going to I'll talk to you a little bit about me, my history of the procedure itself. We'll describe the procedure, its clinical applications in other GI tumors as well as gastric cancer, and then we'll have an open discussion. Next slide. I like to say that I'm made American with Cuban parts. I'm a son of parents that are both Cuban immigrants. I'm a surgical oncologist, and as they explained, I specialize in GI tumors, robotic surgery, and HIPEC. Next. My wife and I have 3 children. My first one's Carolina, then Camille, and my last one, Charlotte. We thought we were going to have at least 1 boy, but we're on track for 3, possibly a 4th girl along the way. So I like to say that I'm a dance dad at this point, and definitely have a lot more gray hairs now with 3 daughters at home. Next slide. So I thought this quote was very appropriate. Those diseases which medicine do not cure, the knife cures. Those which knife cannot cure, fire cures. And those which fire cannot cure are to be reckoned wholly incurable. And if you think about things, our treatment of cancer right now is limited to 3 modalities, which is surgery, the knife, radiation therapy, which is the fire, and chemotherapy. And very frequently when those therapies fail, then we're left with an incurable situation. Next. So some terms to kind of keep in mind as we go forward. Peritoneal surface malignancy is a broad term for any cancer which spread to the lining of the surfaces of the abdominal cavity. So basically any GI tumor, stomach, pancreas, colorectal, appendiceal, ovarian, in fact, they can have shedding of cancer cells that will lay on the surface of the organs and cause what we call peritoneal surface malignancy. Cytoreductive surgery is in reference to an operation, and it could be a very different operation depending on the extent of disease, where we physically remove any visible disease. So if someone has, for example, gastric cancer and it spread to the surface lining of a small intestine or the ovary or the liver, we would go in and remove all visible disease. And HIPEC, as we described, is basically the administration of a heated, concentrated chemotherapy directly into the abdominal cavity. So, I kind of try to explain it's kind of like a washing machine, where the abdominal cavity is a washing machine. The intestines are what we're trying to clean out, and we're trying to clean it out and kill any malignant cells that are in the abdominal cavity to try to prevent it from returning. Next. Next slide. So the concept of hyperthermic intraperitoneal chemotherapy isn't a new one. Really, in the late 70s, we began to do studies that showed that chemotherapy agents leave the peritoneal space, so the abdominal cavity, at a slower rate than the body metabolizes or excretes a drug when it's given intravenously. So it was felt that we could maximize this and we could administer drugs into the cavity at a higher concentration with possibly less systemic toxicity. Next slide. During this time, a lot of studies started, a lot of interest came about in this technique. One of the original studies in 1980, which was an animal model, had mice that they had instilled within the abdominal cavity cancer cells. They were treated with a heated solution which circulated in the cavity. And they found that in the animal model, there was a better survival in the rats that were treated with the heated saline than the mice that were control groups that didn't receive the heated saline. Next slide. In 1980, they actually described the first HIPEC procedure, and it was part of a master's thesis at the University of Missouri. The patient was a gentleman with pseudomyxoma peritoni, which is a type of appendiceal tumor that when it ruptures secretes a mucin, which is cancer-like, but isn't exactly cancer. Next slide. They found, this was published in Cancer Research, and they recorded there was no adverse events. Patient had a repeat procedure 8 days later, but they don't really document the long-term outcomes. This was unknown. Next. Now, interestingly, one of the first to be interested in this technique was really the Japanese. And this interest was brought up because the Japanese have a very high incidence of gastric cancer in their community. And gastric cancer is one of the diseases that has the highest predisposition to shed cells and create carcinomatosis as part of their metastasis. And basically, their studies looked at epithelioma cells that were injected into the cavity. They developed a drug called mitomycin C, which is actually one of the drugs that we still use for GI tumors to date. And they showed that there was a survival advantage when these animals were treated with mitomycin C and heat versus mitomycin alone. Next. Now, the person who really was at the forefront, who really developed the technique, is Dr. Paul Sugarbaker. He, in the early 90s, began to use this and really explore its uses in different diseases. A lot of the key concepts that we use today in the treatment is really based on years and years of his research. And, his research basically shows a lot of the similar things, that you can get very high concentrations of chemotherapy within the abdominal cavity. And this would help facilitate penetration into these cancer nodules that are on the surface of the organs. And a very important fact that he noticed was that there was no long-term survival if you did this technique of the chemotherapy in patients with visible cancer. Next slide. So, he was really one of the people that was in the forefront of developing this technique and this thought process that, yes, this is valid, but it's only applicable in those patients who we can perform a complete cytoreduction, meaning that we remove all visible disease. And he developed what we call the peritoneal cancer index. Next slide. The peritoneal cancer index, or PCI score, is something that we use to evaluate patients for this type of therapy. Basically, the radiologist divides the abdomen into quarters and divides the small bowel into sections so that there's 13 regions 0 through 12. Then we assign a point to each region based on the volume of disease. If there's no tumor seen, then we give it a 0. If there's a tumor less than 0.5 centimeters, it gets a 1 point. If it's a tumor or a conglomerate of tumors that are up to 5 centimeters, you get 2 points. And a 3 would be anything greater than 5 centimeters. Then we add up these points. The highest score possible will be a 39, and the lowest would be 0. And any patient being evaluated for possible cytoreduction in HIPEC will have imaging and will determine what the PCI score and determine whether or not they're a candidate for surgery. Now, these PCI scores are important because they vary from disease to disease. In general, the more indolent the disease, then such as like an appendiceal tumor, who tend to be a little bit more indolent, we can tolerate a higher PCI score, which would require a more aggressive operation, where a more aggressive disease, something like gastric cancer, we really need to be in a lower PCI score. So, this is a very important step with regards to determining a patient's candidacy for this treatment and trying to predict whether or not it would be of any benefit. Next step. So cytoreductive surgery, again, is a broad term which can incorporate anything. It could be colon resection, peritonectomy, omentum, small bowel. Basically, it's removal of any visible disease, and any innocent bystander gets removed. So for us to deem someone as a surgical candidate, we have to be able, again, to remove all visible disease, but we also have to be able to leave behind anything that's necessary. So things we look at to try to determine or feel that this operation is contraindicated are things that would be surgically prohibited. So for example, if there's cancer throughout the entire small intestine, it's not feasible to remove someone's entire small intestine. So that would be a contraindication. If there was disease, for example, extensive throughout the pancreas, well, we wouldn't remove the entire pancreas for the sake of removing the tumor. So, the operations can sometimes be simple, sometimes they can be complex, but they have to obviously leave us with all the necessary parts for our body to be working. Next slide. Post-op, we determine someone's cytoreductive score. If we score them a 0, it means that at the end of the case, if you look in the abdomen, there's no visible disease. If we see small nodules measuring less than 2.5 millimeters, then that's considered a 1. And a 2 or 3 is really more gross disease. I put arrows next to 0 and 1 because that is what we consider an ideal complete cytoreduction, because there's limitations with regards to the size of the residual peritoneal tumors and the ability of the chemotherapy to enter that via diffusion. So, if at the time of surgery in our operative room, we'll dictate, a score of 0, 1, 2, or 3, and we can use this to determine the candidacy for the HIPEC and to give it there or not, and also help stratify risk of recurrence. Next slide. So these are kind of broad terms with regards to complication, because a lot of it really depends on the extent of the operation. But if you look across all comers, all across literature, the mortality can be shown to be between 0 or 18%. Complication rates of 0 to 45. Neutropenias, which is a dropping of your white cells, white count 5 to 30%, and pulmonary issues like pneumonia about 10 to 16%. Reviewing our numbers thankfully are lower than these, but these are the numbers that are generally quoted as possible complication rates. Next. So how do we perform the procedure? First is you complete the operation, which is individualized for each patient based on where the tumors are located. Right before we're done with the operation, we cool the patient off to 35 Celsius. We place 2 inflow catheters into the abdomen. We place 2 outflow catheters, which have temperature probes to measure the temperature of the fluid coming in and the fluid coming out. At that point, the abdomen is closed. We fill the abdominal cavity with fluid, usually around 3 liters of fluid. Next slide. This is an example of on the screen's left, of a patient who had an open operation, and those are the 4 catheters that we use for the chemotherapy. On the screen's right is an example of a laparoscopic procedure where we have the catheters placed through the previously used laparoscopic port sites. Next. At this point, we establish a flow rate of at least 1 liter per minute maintained by the perfusionist, and then we establish an inflow temperature of 43 degrees Celsius with a target outflow of 40 minutes. And once we have this circuit established, then we administer the chemotherapy into the circuit, and that runs from 90 to about 120 minutes, depending on the chemotherapy agent we're using. Next up, next page. Here we see the perfusion machine, and that's myself during one of the operations. Next slide. And here you'll see our resident introducing the chemotherapy into the circuit. And then this is the pump that's circulating the chemotherapy into the abdominal cavity, with the catheters that are circulating the chemotherapy into the cavity and out of the cavity. And again, this process runs for about 90 minutes to 120 minutes, depending on the chemotherapy and disease that we're treating. Next up, next. So, I put this kind of joking around in the sense that, there has to be an ideal scenario for this to work. It's silly to think of just throwing water with chemotherapy over a tumor and think that that's going to decrease this tumor's growth. It really has to be an ideal situation that has a complete reduction of all tumor burden for this technique to work. Next. So I'm going to give you a couple quotes that I think are really the premise of how I try to think about all patients. So, this quote by Dr. Blake Cady says, biology is the king, and the selection of cases is queen, and the technical details of the procedure are the princes and princesses of the realm who try to overthrow the forces of the king and queen, usually to no long-term avail, although with some temporary apparent victories. Next slide. And next one I think is important is in God we trust, and all others must bring the data. Next slide. So for me, when we talk about peritoneal tumors and cytoreductive surgery and HIPEC, the in God we trust is really the appendiceal tumors. These are the tumors that have the longest history of being treated with this technique. It's really the one that has the most data supporting its use. And all others must bring data. I consider the colorectal, the ovarian, the gastric, because this is still a technique that is in evolution. As of recently, colorectal cancer, the NCCN guidelines has included cytoreductive surgery and HIPEC as a potential treatment for colorectal cancer. So it's part of our NCCN national guidelines. For ovarian cancer, based on more recent literature, it's also a part of our guidelines now. It's something that is thought to be considered in patients with stage 3 or stage 4 ovarian cancer. It is not yet part of the national guidelines for gastric cancer. We're not there yet with regards to gastric. Next slide. So we'll talk a little bit briefly so you can kind of get a perspective of what this does in other diseases versus gastric. So, appendiceal tumor is very rare, biologically diverse tumors, found in about 1% of all appendectomy specimens, usually people coming in with appendicitis, and account for 1% of all GI tumors. Next. A lot of sugar breakers data showed that there was a significant improvement in survival if you were, again, able to remove all visible disease, and it was stratified also based on pathology. The more benign type pathology did better, obviously, and the poorer pathology did worse. But here we're seeing patients who have extensive disease, bellies full of tumors, and if we reference that PCI score, I'm talking about a very high score. It could be in the high 20s, even 30s. Someone who, if you saw a CAT scan, would think there's no way this person is going to survive this disease. Here we're seeing 5-year survival rates of 86%, and in hybrid pathology, tumors that are mixed, less aggressive, more aggressive, about 50%. And in the ones who you could not remove all the disease, they had the worst 5-year and 10-year survival of 20%. So, this data really supports the notion that for a good outcome, you have to remove all visible disease. And, a lot of the outcome is going to be dictated by pathology. And the PCI score of what we're able to tolerate in order to give this treatment is really tumor dependent. So again, a disease that has a huge spread in the abdomen, looks very aggressive, can behave aggressively if not treated, but despite this extensive disease, responds exceptionally well to this concept of debulking, cytoreductive surgery and HIPEC. Next. Colorectal cancer, a big issue in the U.S., third most common cancer globally, second for cancer-related mortality. In its early stage, patients do well, 72 to 92% 5-year survival, but 25% of patients, so 1 in 4, have metastatic disease at the time of diagnosis, and about 30% of patients who have a curative operation will have recurrence. Next slide. 1/4, or 25% of patients will have what we call peritoneal limited disease. So, colon cancer can spread to the liver, can spread to the lung, can spread to bones, but 1 in 4 patients will have disease that's only spread to the intestinal lining. And if we look at autopsy studies of patients who've had colon cancer, up to 40 to 80% of patients can have unknown spread of cancer to the lining of the abdomen, that's only identified at the time of autopsy. So clearly it has a high predisposition to spreading to the lining of the intestines. Now, historically, carcinomatosis, or cancer spread to the lining of the intestine for colon cancer, was considered a terminal disease. If you developed carcinomatosis, it was basically just palliative chemotherapy. Next slide. This has changed with time. With modern chemotherapy, the best survival reported for carcinomatosis with chemotherapy alone, this is non-operative. Someone presented with colon cancer, they had surgery, cancer came back, they're told you're not a candidate for surgery. Best survival with modern chemotherapy is about 15 to 23 months. Next slide. Colorectal cancer is, however, one of those diseases that we do operate on metastatic disease. It's very well established for isolated lung tumors, very well documented for liver metastasis. So it's not uncommon for my partner and I to operate on patients with colon cancer that returned as a metastasis to the liver, or the thoracic surgeon to operate on a lung tumor from colorectal cancer. But the concept of operating on carcinomatosis, metastasis on the lining of the abdomen, of the abdominal intestines, that was always felt to be something that we did not offer surgery for. And again, it was felt to be an end of disease process that was only treated with palliative chemotherapy. But we're finding that with more aggressive management between combining chemotherapy and surgery and HIPEC, we're increasing our survival, and some are, we're getting long-term survivals over 50% in these patients. Next slide. So this is a study from 2003 that was basically in an era of older chemotherapies, which is the standard 5-FU-leucovorin, which is just a subset of the chemotherapies we use now. And they basically looked at surgery plus HIPEC versus the older type of chemotherapy that we used in the late 1990s. And we saw that the HIPEC group had a much better survival than the patients who just got chemotherapy, 22 months versus 12.6 months. Next slide. And the only real long-term survivors were the patients in the HIPEC arm. There were 45% of patients in that arm were alive 8 years after their surgery. And one of the things that's been discussed about this study now in retrospect is that now that we've added agents like oxaliplatin, irinotecan that are significantly better, this would probably narrow the gap and eliminate the survival difference between these two groups. So at this point, we're wondering, well, now that we have better chemotherapies, do we really need the surgery? Because we could probably make that up, that survival, with these new chemotherapies. Next slide. So what does that mean? So now we have patients with colorectal cancer that spread to the lining of the intestines that traditionally wouldn't be operated on. Now they have a chemotherapy agent that improves their survival significantly more just with chemotherapy, better than what we would have done with surgery and HIPEC. And this study, the Prodigy 7 trial, said, well, what if we add surgery and HIPEC now in addition to that great quality new chemotherapy? And this group, they randomized patients into surgery and HIPEC versus just the surgery alone. And what we found was in this group of PCIs, 11 to 15, that middle group, there was an improvement in survival, 42 months versus 32 months. So an extra 10 months of survival that's felt to be related to the surgery and HIPEC. And keep in mind, look at these numbers compared to the other, where we're talking about, 12 to, about 12 months versus 22 months survival. Next slide. Now, gastric cancer is a little bit different than colon, although we're trying to model our treatment to colon. Fifth most common cancer worldwide, third most common cause of cancer death worldwide. 35% of patients will present with synchronous metastasis. That means that you have metastatic disease at the time of your diagnosis, and 35% of patients will have cancer come back after a curative operation. And in about 9% of patients who present with cancer, a good 9 to 10% of patients will have peritoneal only disease, meaning their only site of metastatic disease is in the lining of the intestines. Next slide. Now, when we look at patients who've had surgery, depending on which studies you read, about 10 to 46% will have peritoneal recurrence only after surgery. So you had surgery and the cancer came back. It didn't go to the lungs, didn't go to the liver. It only went to the lining of the intestines. And it can be the only site for a grand majority of patients. Now, prognosis-wise, this has the worst prognosis compared to other sites, with a median survival of 3 to 7 months and a 5-year survival of 0%. So a very aggressive feature. Next slide. And and this is important because we've noticed even in patients that we have negative imaging, we have CAT scans that are negative, PET scans that are negative. Over about a third, 30% of patients will have visible metastatic disease on the peritoneal lining when we do a diagnostic laparoscopy and we take a look prior to surgery. So this is just to underscore what a huge problem this is for patients with gastric cancer. I mean, it's a very common site of disease at the time of diagnosis. It's a very common site of disease at the time of recurrence. Patients who have seemingly negative CAT scans for metastatic disease, a third of them will actually have disease. And it's one of the most aggressive sites where the cancer can recur for the disease. So with that said, we're being very aggressive about trying to find ways that we can be more aggressive and offer improved local regional treatments to these patients, knowing that it's a huge problem for the subset of patients. Next slide. So what are the differences here? So colorectal cancer, we have screening, so we tend to catch patients earlier. Gastric cancer, we don't have screenings. Colorectal cancer, we have multiple chemotherapies that will facilitate getting someone to HIPEC. So for example, you may have someone with high burden of disease. We give them chemotherapy. 50% of that cancer disappears. It makes the operation easier. We can get most of it out, and now the HIPEC works better. In gastric, we have limited chemotherapies that are less responsive. So it doesn't have that same effect to kind of get someone to cytoreductive surgery in HIPEC. In colorectal cancer, we routinely operate on metastatic disease, again, because we have effective chemotherapies that can help bridge a patient or convert someone from what we consider inoperable to operable. The national guidelines right now for gastric is that we don't operate on metastatic disease. As soon as we see something spread anywhere, whether it's a big tumor or a small tiny thing, it's considered stage 4, and surgery is not the standard of care. And for colorectal, we have a large volume of patients that we can try different techniques and do studies. Gastric is a very small subset of patients to study these techniques. So that being said, it becomes a more difficult group to study and to try to perform large, what we call randomized controlled studies, where we put one person in one group, one person in another, and really have a rigorous scientific assessment of how well this treatment works. So most of our data is based on smaller studies, retrospective studies, individual institutions' experiences with the technique. Next slide. So this is kind of the normal algorithm. In the green, we have the patient with early disease that's operable. They go to surgery. It's rare to find these patients. In the blue, we have the operable but a little bit more advanced. Most of these patients will be getting preoperative chemotherapy, then surgery, and then sometimes postoperative chemotherapy. And again, in the pink, we see the inoperable or metastatic disease. There's no surgery in that algorithm. It's basically palliative chemotherapy. Next slide. So, no, one back. So what we're trying to do, and the paradigm shift we're trying to develop in gastric cancer, and I think with time, as we get better chemotherapy, this is going to become more and more true, is that we're trying to get patients back into the path of surgery. There is no solid organ tumor that can be cured without an operation. As soon as we take surgery off the table, we're in palliative mode, and the chance for cure is 0. So here we're trying to flip the switch and trying to convert the patient into an operable patient. And the strategies are early intervention with chemotherapy, and hopefully now HIPEC to try to treat the disease, which normally would have been a contraindication for an operation. Next slide. So again, surgery for gastric cancer is limited to local regional disease that's just limited to the stomach. Here's a picture of cancer implants on the abdominal wall during a laparoscopy when we're taking a look inside. This is what we're faced with and what we have to deal with from a surgical issue and as well as from a HIPEC issue. Next. So, again, although a patient with gastric cancer can develop liver or lung, the peritoneal spread is really the most frequent at the time of diagnosis and recurrence, and this is why there's an effort to improve the outcomes by selecting patients that we believe will benefit from cytoreductive surgery plus HIPEC. Next. So, what's the data we have? So, there's a study from 2011, which was a randomized controlled trial looking at surgery versus surgery plus HIPEC. But again, a very small number of patients because it's very difficult to find the right candidate. Most patients present with a disease that's too far along for us to really entertain this treatment. These patients were treated with platinum and mitomycin, which are 2 chemotherapy drugs and actually the ones that we use in our practice. And when we looked at median survival, for the surgery group was 6.5 months versus surgery plus HIPEC, which is 11. Now, you may look at this and think, well, 6 to 11, 6, 7, 8, 9, 10, that's about 4 to 5 months difference in survival. But if we look at the FDA approved drugs for some chemotherapy agents, sometimes the numbers are lower than this. So whenever a new chemotherapy drug comes out, it's going to come out, it's first tested in the metastatic disease setting. It's offered to patients with metastatic disease. And then we assess response. We look at imaging, we look at survival, we look at progression-free survival, how long are they alive before the cancer comes back. And to give you an example, one of the most recent studies, the Checkmate 649 trial, looking at something that's called a PD-1 inhibitor, showed a statistically significant survival advantage in patients who took this new drug with regular chemotherapy versus the chemotherapy group. And the difference in survival was 3 months, 14.4 versus 11.1 months. And this drug was approved for the use in metastatic disease, and it's now considered standard of care for adjuvant therapy given after surgery, in addition to chemotherapy. So when we look at these survival differences, 5, 6 months, we have to put it in perspective with our near chemotherapy agents and the fact that we get excited when we have a new drug that improves your survival by 3 months. So that being said, this number is comparable, if not better, than some of the most recent trials with newer drugs and survival advantage. Next. This is a meta-analysis which looked at 11 trials, and a meta-analysis is basically someone that says, all right, let's review the literature, let's get all the best quality data and put it together and see, what we get when we put different studies together. And so they had 11 randomized trials, 21 prospective trials. These are trials where someone had a treatment and just gathered data. Overall, there was data on about 2,500 patients, and their review of 30-year experience with this technique showed a increase in survival in 4 months. Now, we have to remember, again, 4 months doesn't sound exciting, but we have to put it in perspective with newer drugs. And we have to think that over 30 years experience, we've had dramatic changes in chemotherapies, which would probably increase the length of survival in this patient population. But again, there seems to be something in the water where the addition of this treatment to contemporary chemotherapy alone seems to give a survival advantage. Next. Here, retrospective study looking at 88 patients in 8 specialized Spanish institutions. Something that was key for them is that they kept their patient populations with a very low PCI score, a PCI score of 6. And because of this, they were able to get a complete cytoreduction, removal of all visible disease in 91% of patients. And HIPEC was administered in 85 cases with 4 different regimens, which is one of the limitations of the study. Next. In this group of patients, the median overall survival was 21.2 months. There was a 1-year survival of 80% and a 3-year survival of 30%. So now we're seeing what appears to be a dramatic improvement in overall survival based on an operation which at present is considered not indicated with the addition of hyperthermic intraperitoneal chemotherapy. Next step, next slide. And when they do the multivariate analysis, basically the statistician looks at every single variable and tries to account for all the differences in variables, for age differences, for gender differences, for weight, for the only predictive factor, the only independent factor that they looked at that influenced the patient's survival was the extent of disease. So in their study, the only patient that did better with this technique were patients with a PCI score less than 7. And that would predict an improvement in survival. And by default, that's really our kind of general cutoff in patients for gastric cancer, the PCI score under 7. Next. So the cytochip study is one of the more latest studies, and it's really one of the studies that's gotten people recently more excited about the technique. It was a prospective database with 277 patients out of 19 French centers from 1989 to 2014 that had a very aggressive cytoreductive and HIPEC programs. 180 patients had surgery plus HIPEC. 97 patients had surgery alone. Next. Here, the median PCI was higher in the surgery plus HIPEC group. So it was actually a group that had more disease, and 6 versus 2. And the median survival in surgery and HIPEC was 18.8 versus 12.1. So about a little over 6, close to 7 months additional survival in this patient population. Next slide. When we looked at the median 3 to 5 year overall survival, the surgery plus HIPEC had a 26.2% 3-year and a 19.8% 5-year survival. Now, this is a patient population that typically, with only chemotherapy, we're reporting a 0% 5-year survival. And the surgery alone group, which in and of itself is a novel approach to this disease, because surgery in and of itself alone is not considered standard of care for patients with gastric cancer with peritoneal spread. They also have some 5-year survival rates of 6.4%. So, you know, what makes this study interesting is that it's kind of changing. It's giving us the same kind of like the same paradigm shift that we saw in colorectal, that a group of patients who were not offered surgery seem to do better with surgery, and if you do surgery and add HIPEC, those people tend to do better as well. Next slide. So, you know, there seems to be, again, a general trend in selection of patients for this technique. It's got to be someone with a good performance status, someone that can tolerate an operation. We need to have resectable disease, clearly, because the HIPEC will not work if the disease is unresectable. If you have an aggressive pathology, we have to have a lower PCI score. If we have a less aggressive, we can entertain the treatment with a higher PCI score. We got to select the right chemotherapeutic agents, and that's something that every center has their own drug regimens that they use. Right now, there isn't anything that's standardized. What we did when I came on board at Memorial is that we in developing the program, we collaborated very closely with pharmacy, and we basically did an extensive literature review with regards to what drugs have been used, which ones are the ones that were most efficacious, which one are the ones that had the best risk profile. And then once we selected those drugs, we went back to the biochemistry of it and decided, well, what are the highest drug concentrations we can use, the most aggressive dosing, before we're at a point that we're increasing the patient's risk. And then a large part of this is also minimizing the postoperative risk, because most patients will need to go back to chemotherapy, and we want to try to get them through to recover as quickly as possible to get them to a new treatment. Next slide. So in our program, again, we treat appendiceal, colorectal, ovarian, gastric, mesothelioma. Next slide. For gastric cancer mesothelioma, we use a combination of mitomycin and cisplatin. Next slide. We have a risk-stratified enhanced recovery protocol that we're piloting now. And basically, we stratify patients to low risk, intermediate risk, or high risk. And depending on the risk is how we manage patients postoperatively and what our anticipated length of stay is. So if you fall into the low risk category, you know, your predicted anticipated discharge date is 5 days. If you're high risk, you're 12. The risk is really determined on some factors. A large part of it is what operation we perform. In patients who are undergoing gastrectomy, pancreatectomy, or liver resection, we consider all these patients high risk. So the anticipated length of stay is about 12 days. Usually you have a tube in your nose for 3 days to facilitate the healing of the connection. You'll have a catheter in your bladder to monitor your urine for about 3 days. We start a diet on post-op day 3. And again, anticipated length of stay is about 12 days. Next slide. Preoperatively, as part of the enhanced recovery program, we always have the patient see anesthesia testing for consultations to see if there's, so they can discuss their anesthesia techniques. One of the things that we've done with anesthesia is be very aggressive with the fluid resuscitation. We have a fluid limited protocol where we really try to limit the amount of volume we give patients, because we recognize that giving patients too much fluid during the surgery delays the recovery, can make the intestines become inflamed, can lead to complications like an anastomotic leak where the intestines don't heal, or you have pneumonias, or you have difficulty breathing from being fluid overloaded. We partner with integrated medicine that we usually have the patient be seen preoperatively to help assess quality of life assessment, nutritional assessment, preoperative dietary plans to really make sure that from a dietary standpoint and from a physical standpoint, you're as robust as you can be and as strong for the operation. Usually, traditionally, patients would not have anything to eat or drink from the night before surgery, and they wouldn't eat for several days until after surgery. Now we have them do a carbohydrate loading where the night before they go to bed, they have a high carbohydrate drink. They have another one in the morning, and this has been shown to expedite recovery. We have a special bowel regimen to clean the bowels with antibiotics. In the OR, the anesthesiologist will do a ultrasound-guided injection of the abdominal wall nerves so that we can limit the postoperative pain, get you out of bed quicker, get you moving faster, get you to avoid having to take a lot of narcotics for pain management, which can affect the function of your intestines. We spoke about the goal-directed fluid resuscitation, where we really limit the volume. We only give the necessary amount of fluid to the patient to keep them going, rather than flood them with fluids and later on, have someone who's edematous, who's fluid overloaded. And we try to limit the narcotics by combining different regimens. You have an anti-inflammatory that we give. You have gabapentin, which has its own mechanism of action for pain management, combination of Tylenol and some narcotics. Post-op, we follow the ERAS protocol that we spoke about. We get physical therapy involved, multimodal pain management, social work services to try to facilitate discharge and make sure the patient has everything they need in order to go home safely, and spiritual support services as requested as needed. Next. Now, this is the algorithm we follow. This is an algorithm established by the 2018 Chicago Consensus on Peritoneal Surface Malignancies. So here we have on the screen left, patient has gastric cancer with proved peritoneal metastasis that was seen on biopsy or washing. The case is presented at our tumor board. We review all imaging. The initial treatment is really standard of care therapy, which is chemotherapy for 3 to 6 months. Then we get restaging, repeat imaging, to make sure that we don't have progression of disease, make sure that we have stable disease. At this point, we consider another laparoscopy to assess the extent of disease. And on the top, if a patient has a high PCI score, then the strategy doesn't work. Our recommendation is to proceed with standard of care, chemotherapy, clinical trial, best supportive care. Now, below, in the patient that has stable disease or improvement, and no extraperitoneal, no liver metastasis, no lung metastasis, nothing anywhere else, has a good performance status. If they have a low PCI score, which for us is 7 and under, then we recommend surgery with the HIPEC. If you have a high PCI, but you have a good performance status, and we feel that you're someone that we may still be able to offer surgery, there are times that we offer a laparoscopic HIPEC to treat the peritoneal disease and see if we can reduce the burden of the disease in order to eventually offer surgery with HIPEC, depending on their progression or stability of the disease. And I think that's all I've got for you. Next slide. All right, thank you. I know that's a lot to take in one sitting. I'm happy to entertain questions.
Thank you so much for sharing with us today, Dr. Laguna. We have received some questions during your presentation, so I would like to ask a few in our remaining time. So one of those questions is HIPEC covered by my insurance?
I'm sorry?
Is HIPEC covered by my insurance?
So it's very limited. Some insurance providers will cover it, some don't. We haven't really had much of an issue. And I think that the reason we haven't had much issue is that it's really more of a technical glitch than not. Whenever we consent someone for surgery, we're never sure if they're going to be a HIPEC candidate or not. So when we get our authorization, the authorization usually reads diagnostic laparoscopy, bowel resection, possible HIPEC. It seems to be it seems to be a technical glitch that if it's possible, it really isn't part of the authorization. So we really haven't had any issues having patients authorized. Now, if we do say 100% HIPEC, then sometimes they get denied. We have to write letters to request for it. We have to do like a peer-to-peer, and it can sometimes be challenging to get it covered under that setting. But since I realize that that once it's documented as possible, we haven't had any issues really getting it approved in retrospect.
Okay, thank you so much for answering that. Our next question is, will this treatment be the standard of care?
So I hope so at one point. I think the best example of how, as we learn more of a disease, our treatment for that disease changes is breast cancer. So breast cancer, we started off with a very aggressive operation where you took out the entire breast and the muscle underneath and all the lymph nodes. And as chemotherapy got better, our surgery got smaller and smaller. And the better chemotherapy gets, the more we can do from a surgical standpoint. So colon, for example, over the last 20 years, there's been a change in our chemotherapy agents, and we went from, surgery for this is not recommended, just chemotherapy, to, wow, our chemotherapy is better, and now we can operate, and the outcomes of combined treatment are better. So I hope that at some point, we don't need any surgery. I hope at some point there's a pill that we can take and we'll take care of everything. But I think the natural progression is going to be the better chemotherapy we have, the more we can keep the cancer at bay, and the more role there is to go in and remove whatever visible disease. Because it's a combination of things. And if you notice, the patients that do the best in these strategies are the ones that have, good chemotherapy options. So, for example, ovarian cancer, when we do this operation for ovarian cancer, we're as a general term, we're kind of less aggressive with the operation because the chemotherapy works so well that whatever residual disease we have left, the chemotherapy very often just makes it disappear. So, and in that subset of patients that can have extensive disease and chemotherapy that works well, adding the surgery and adding the HIPEC has improved survival. So again, it's a combination of things. And I think for this to become standard of care, we're going to have to get to a point that we just have better chemotherapy so we can get patients with high PCI scores to lower, be able to remove it, treat it aggressively, and then have the backup of the chemotherapy. I think for now, given our limitations, especially with chemotherapy, it really should be reserved to patients that have low burden of disease.
Thank you, Dr. Laguna. Another question came in. It's pretty lengthy, but I think I can synthesize it. It says, how are we trying to change the current mindset of surgeons who won't operate on later stage gastric cancer patients? And how do we get more chemo options when we're the least federally funded of all the deadly cancers?
Right. So, I think for now, any surgeon that sees a patient with metastatic disease, I don't think should operate on a patient. I think right now the standard of care is really chemotherapy for patients with metastatic disease. So I don't think we necessarily need to change the perception of surgeons who will or won't. Now, I do think that we have to have a level of compassionate care where we recognize that there is a subset of patients that we may be able to impact, by going off of the standard pathway. But in order to do that, I think it has to be someone who really understands the disease. And I think that holds true for any disease. You have to know the rules before you bend them. And I think every patient that has a disease where surgery is not the standard of care, if you operate, you run the risk of having a poorer outcome. But there are a subset of patients that you may be able to improve their outcomes. And with time, that experience will grow and the knowledge of the disease will grow. And as things evolve, may become standard. So for now, I don't think anyone should be operated on with metastatic gastric outside of the setting of a cancer center with a peritoneal, if we're talking about just peritoneal metastasis, a peritoneal metastasis in a patient who's been presented at a tumor board, and it's been agreed that we may be able to offer patient, a survival advantage with this treatment. Now, you're right. We need to have more research and we need to develop better drugs so that we can open up options to patients. And again, in my mind, very simply speaking, as soon as we take surgery off the table, then there's no curative pathway. Now, that's not to say that we're in a state right now that we can cure metastatic gastric cancer with HIPEC and surgery. We're at a state that I believe that in the correctly selected patient, we're giving them a chance to improve their survival, and we likely will. But it's going to take a while before we're at a stage where that's going to be considered a standard of care. And if you're not doing that, you're doing the wrong thing for the patient.
Thank you. We had another question. Someone just wanted to clarify, is it true that HIPEC is not given to patients with metastases outside of the abdomen?
Right. So in general, it's offered to patients who only have isolated peritoneal disease, only disease that's on the surface of the organ. Now, I can tell you that we've had exceptions. So Just recently, I had a patient, for example, that has colon cancer, had their operation, had a liver mass, a lung mass and a liver mass. The liver had been operated on and was removed. The lung had a small 1 centimeter tumor that was treated with radiation therapy. A year has gone by, and he developed low volume peritoneal disease. And now the patient is like 4 years out of his initial diagnosis, 2 years out of his liver resection, the liver's clean, a year out of the radiation of his lung, and he's had stable peritoneal disease for about 9 months. That patient, we presented at tumor board, we spoke to the medical oncologist, radiation oncologist, and we decided to offer him surgery in HIPEC. And if he does well, we're going to go back and remove the lung. So, these are all cases that are thought of like in an individual basis. The important thing here is that everything is about patient selection. You have to have the right patient, and you have to match the right disease to the right treatment. And so if I would have seen that patient when he first had the liver met, I would have said no. But now that time has gone by and everything seems to be stable, and the only side is, then we offered that patient. Where if I would have seen him early on, I would have said you're not a candidate for this at this time. So it's very important to select your patients well, and that's why it's very important that it's someone who understands the disease, and that there's a lot of communication between the entire team. So there's no one that I operate on that this case has not been discussed in a multidisciplinary fashion, where everyone involved in the care, medical oncology, radiation oncology, everyone has seen every fact and agrees on the strategy and the plan. When I started my surgical oncology fellowship, I remember sitting at tumor board, and they would present patients, and I would whisper to the intern next to me, that patient can only get chemotherapy, there's nothing else to do. And then they would devise this plan that over the course of a year would get the patient to chemotherapy, whether it was chemo, radiation, operating this, removing that. And after a while, I realized that the purpose of me being there wasn't to learn how to operate more, it was to understand the disease so that I can know my opponent and know how to best fight it. And the armamentarium we have to fight it is chemotherapy, radiation, and surgery. And in each patient, we have to look at it in those three specialties and figure out, where do we hit you next? Where do we hit you next? And can we get you to surgery, knowing that that is always going to offer the best survival advantage? But to do that requires, again, knowledge of the disease, knowledge of that patient's history, an understanding of the timelines of things, and the interaction with the other specialists that are taking care of the patients. You can have two patients that have the same cancer, an identical looking scan, and one person might be an excellent candidate, and one person would be someone that we would never operate on. So these are cases that are looked at all, on a very individualized manner to make sure that the treatment fits their disease. Now, with that, I tell everybody, and I'm a firm believer that just because you do the right thing doesn't always mean you get the outcome you want, right? So sometimes we're blessed and we make the right decisions, and the outcomes are great, but sometimes we make the right decision and the outcomes are poor. But in those settings, I think the solace is that when the outcomes are poor, usually that's disease driven, and the patient is in a situation where you have very limited options, and some patients, when they have limited options, want to pursue any therapy within reason that might offer them some palliation or a potential cure of that disease. And I think that's what we're here for. We're here to figure out, can we outfox this disease to get you to live longer and have, quality of life during that time. There are a lot of patients that we evaluate that we say, unfortunately, I would love to be able to operate and think that I'm going to do something positive, but I don't believe so, and we turn down. And others that, that based on the data we have, we say it's very reasonable for us to entertain this. We may be going off of what the quote unquote standard of care is, but again, it goes back to the idea that you've got to know the rules in order to bend them. And to bend them, that's with the input of all the specialists that are taking care of every facet of this patient's disease.
Thank you. We have two more questions. So one of them is from a patient who just the celiac node showed a small growth 6 weeks after his CRS HIPEC at Johns Hopkins, and he's now on Keytruda, and he wants to know what's the best possibility of Keytruda dealing with this development. He has 3 infusions and 1 more is scheduled.
Right. I mean, that. I mean, I'm not. Oh, I don't know off the top of my head the response rates of Keytruda with regards to nodal disease by itself. I mean, the medical oncologist probably be able to give you a more realistic answer to that. I'm sorry. I wish I could answer the question.
Thank you. And what are, besides your program, what are the best locations to have HIPEC treatment?
I mean, so we have our pro here in this area. Really, it's really just us. performs cases, but I'm not sure if they have a program, but I know they have a Dr. Muller that also performs HIPEC. Outside of here, I would probably say Wake Forest is really like the mecca for HIPEC right now. Memorial also has a program, but it's not as robust as Wake Forest, I would say.
Thank you so much. There's one last question, and that's all we'll have time for, but this person had surgery on January 6th, and they had a spread that was only in the fluid with a PCI of 0 to 1. Right. There was an attachment to the peritoneal surface. What is the chance of reoccurrence?
So there's not recurrence. I mean, the disease is there. So we if the disease is there, we don't really consider a recurrence. You're living with disease. So it's a, recurrence can only really apply if it was all removed and now we're looking to see if something comes back. I mean, was that the case to have surgery or it's just that's what was found?
I'm not sure the type of question. So let's see if they add on to that. Doesn't look like they added on to that.
So most patients, most patients that have any peritoneal disease will recur because and it tends to have a poor prognosis if even when treated. And then the question becomes, what's the best form of treatment? And would it be just IV chemotherapy? But we know that IV chemotherapy doesn't really address the peritoneal lining, as well as other organs like liver and lung, where you're perfusing the organ and you're basically bathing the tumor cells in the chemotherapy. So there's a lot of, whether or not it's going to recur or progress is hard, but it's hard to say with limited information. But a lot of it, I think, is depend on how it was treated. If you have one little nodule, you remove it, that's not the only disease there. There's microscopic disease there that with time has the potential to grow. And the question is, and that's $1 million question is, is it better treated with HIPEC directly to those cancer cells, or do we do the standard chemotherapy? And at least what we're seeing is that there appears to be an advantage to giving what we call local regional treatment directly to the cancer cell in the cavity, more so than just IV chemotherapy.
Thank you so much, Dr. Llaguna. Unfortunately, we're out of time for more questions. Dr. Llaguna, we want to thank you once again for joining us and sharing your expertise.
Perfect. Well, I'm happy to be here. Thank you very much for having me.
Thank you. We would also like to thank our sponsors, title sponsor Merck, platinum sponsors Astellas, Daiichi Sankyo, and Zymeworks, and gold sponsor Bristol Myers Squibb. To view any of our recorded webinars, please visit our lecture library on the Debbie Stream Foundation website at www.debbiestream.org. This concludes today's presentation, and thank you so much for tuning in.